Thank you to everyone who's joining us today from around Australia. Welcome back to Session 2, Deprescribing. First up, let's hear from Professor Sarah Hilmer and Dr. Lisa Koolagian-O'Donnell about approaches to deprescribing of medicines.
Hello, my name's Sarah Hilmer. I'm a clinical pharmacologist and geriatrician, and I'm delighted to talk today about approaches to deprescribing of medicines. These are my disclosures, and the most important one to highlight is that I'm chair of the New South Wales Therapeutic Advisory Group, or New South Wales TAG, which has been very active in developing resources for deprescribing, which are hosted on the New South Wales TAG website. So first question is, what is deprescribing? And it is extremely opportune that we are talking about this at Australia's National Medicine Symposium, because deprescribing is an Australian word. It's an Australian word, just like Barbie is barbecue. Deprescribing was first coined in Australia and first published in the Australian Journal of Pharmacy Practice and Research in 2003. And since then, it's really taken off. And just over a decade later, when a group of us got together to look at what this word actually meant and what the published definition was, we brought those published definitions together to say that deprescribing is the process of withdrawal of an inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. So why are we talking about it today, apart from being an Australian word? Why is deprescribing important for older people? There are three main reasons. Firstly, we have very limited evidence of the benefits of prescribing medications in older people with multimorbidity, polypharmacy, and frailty. People like the patients we see in practice are rarely involved in clinical trials that test the effectiveness or safety of medications. Secondly, we know quite a lot about the risks of polypharmacy in older people, and I'll talk about that in a moment. And thirdly, deprescribing is very person-centred. People do not like to rattle when they walk. And surveys done nationally and internationally with older people and their carers say very clearly that 85 to 90% of people would be very happy to stop one of their medicines if their doctor said that they could. So now we're just going to touch on the risk side. Polypharmacy is associated with adverse geriatric outcomes. For decades, geriatricians have said once you're on 4 or 5 medicines, you're in trouble. And this diagram was propagated by NPS MedicineWise and shows the results of a study that we did in the Concord Health and Ageing in Men cohort, which clearly showed that the cutoff for bad outcomes in older people is actually 4 or 5 medicines. However, it's not just the number of medicines you're on, but also the type and dose of drugs that determines your risk. And the Drug Burden Index is a pharmacological measure of an older person's total exposure to medicines with anticholinergic and sedative effects that impair physical and cognitive function. In order to calculate the Drug Burden Index, use the dose-response equation, which I've put here on the slide. And each drug that the person takes with an anticholinergic or sedative effect gives them a score between 0 and 1, and then you add those up to get the person's total burden. Now, the importance of doing this is it is a really good independent measure of the functional burden of a person's medicines. The higher your exposure to Drug Burden Index, the more likely you are to have impaired physical function, falls, delirium, frailty, wind up in hospital, see a GP, and to die. And this is independent of the number of medicines you're taking. While we initially validated this in a cohort in the US, it's been validated in older people around the world, in the community, in nursing homes, and in hospital. So now that we can see that there could well be a need for deprescribing, the next question is, what are the outcomes of deprescribing? What happens if you deprescribe? Well, you need to think about harms and you need to think about benefits. The types of harms you can think about with deprescribing are adverse drug withdrawal reactions, return of the underlying condition or failure to prevent the condition you're taking the drug to prevent, and the impact of rocking the boat. So the pharmacokinetic and pharmacodynamic effects on your remaining medicines of deprescribing or removing one of your medicines. You also need to think about the benefits of deprescribing. Clearly, the less drugs you're on, the less adverse drug reactions you'll be having, and the less treatment burden you'll have from taking medicines. And this is treatment burden in terms of time as well as cost. What evidence do we have about deprescribing? There I've summarised some of the evidence we have from randomised controlled trials. There are trials that look at single drug classes, and in these trials, usually you're more successful at deprescribing, and you can actually see the impact if you try to focus on the drugs one at a time. So with antihypertensives, we know that if you deprescribe antihypertensives, then depending on your study and its duration and the population, between 20 and 85% of people will still be normotensive over 6 to 60 months. So some people can have their antihypertensive deprescribed and maintain a normal blood pressure. And there's no significant increase in mortality. When it comes to psychotropics, we know if we deprescribe psychotropics, we reduce the risk of falls and we can actually improve cognition or behaviour. And when you deprescribe statins in people thought to be in their last year of life, there's no change in their mortality and a trend towards improved quality of life. What if you focus on deprescribing inappropriate polypharmacy overall? So just look at all the person's drugs and work out which drugs are probably causing more harm than good and could be deprescribed. Well, one of the challenges of those studies is you don't often deprescribe very much. And on average, you deprescribe less than one drug per patient in these studies. However, when you do, you can be reasonably confident that it's safe. There's no impact on mortality overall. And in fact, if you look at people in the subgroup age between 65 and 79, they actually have a slightly reduced mortality if they have an inappropriate drug deprescribed. And the studies have not really been powered to look at this, but none of them have seen a consistent change in falls, cognition, or quality of life. What's really important to note is that in all of these studies, medicines were weaned gradually, often over months, and there was no increased risk of adverse withdrawal events reported. So deprescribing is an important part of prescribing for older people. This is because we have limited evidence of benefit of medications in frail older people, particularly those with multimorbidity and polypharmacy. We have good evidence of the harms of polypharmacy. Deprescribing is person-centred. People do not like to rattle when they walk and are very willing to talk about deprescribing with their doctors. Deprescribing is safe. Now I'm going to hand over to my colleague, Dr. Lisa Kalajian-O'Donnell, to explain how to deprescribe. Thanks, Lisa.
Thank you, Sarah. My name is Dr. Lisa Kalajian-O'Donnell. I'm a lecturer from the Sydney Pharmacy School, the University of Sydney, and today I'll be providing you with tips and tricks to support person-centred deprescribing in practice. I've outlined my disclosures here, and while my research work may overlap with the content of this presentation, I've tried to make every effort to ensure objectivity and balance in my contributions. Following on from Sarah's outline of the basics of deprescribing, what are some of the deprescribing guidelines and tools that are available for use in clinical practice to help healthcare practitioners with implementing deprescribing? I will now outline 6 broad categories of deprescribing tools, of which I'll provide some examples of each. The first category is a general deprescribing guidance. These tools provide general, non-drug specific advice for healthcare professionals about deprescribing. These resources provide background information about the need to deprescribe and principles on how to identify medications suitable for deprescribing. And some include a framework or process. This is the example, one of the examples, and this was developed following the inaugural meeting of the Australian Deprescribing Network, and it guides the practitioner through 4 questions to help them make a decision on whether to commence deprescribing. Another general deprescribing guideline is the deprescribing rainbow, and this tool explains that deprescribing is like a rainbow, highlighting not only the clinical but the psychosocial, social, financial, and physical determinants that should be considered when deciding to start deprescribing. The second type of tools are generic, non-drug specific deprescribing frameworks that provide a stepped approach to deprescribing, highlighting that it is a process rather than a simple one-off interaction. This process doesn't provide specific guidance on how to identify inappropriate medications. Instead, focuses on the process surrounding deprescribing, for example, planning, tapering, monitoring, and documentation. And actually, if you tend to use the AMH Aged Care Companion, the deprescribing guide at the bottom of this section goes through a generic non-drug specific deprescribing framework. For example, it assesses the patient, obtaining the medication history, identifying potential medicines for cessation and prioritizing them, developing a withdrawal plan, and monitoring and documenting the outcomes. Onto drug-specific deprescribing guidelines, and these often provide specific advice on when and in whom it is suitable to trial deprescribing of a specific medication or a class of medications. They also provide guidance on other parts of the process, such as how to withdraw the medications and what monitoring is required. In Australia, several groups have published deprescribing guides, including the New South Wales Therapeutic Advisory Group, and these are examples here, the New South Wales TAG guides, and there's a total of about 8 guides. There's benzodiazepine Z drugs, antipsychotics, SSRIs, anticholinergics, and regular long-term PPIs, for example. And a group from the University of Sydney recently launched the opioid deprescribing guidelines, and there are also guidelines for deprescribing anticholinesterases and memantine by a group led by Emily Reeve from Monash University. Given the increasing uptake of electronic prescribing and electronic medical records, electronic decision support systems enhance deprescribing at the point of care. And there are many CDSSs being developed around the world, including MedStopper in Canada, Taper MD in New Zealand and in Canada. And the work that I've been involved in has been to develop GMEDS, which is the Goal-Directed Medication Review Electronic Decision Support System. And GMEDS provides a person-centered clinical decision support system for healthcare practitioners conducting medication reviews in older people. Within GMEDS, there's a suite of tools to identify and articulate a person's goals of care, calculate the anticholinergic and sedative burden using the DBI, and understand the patient's attitudes towards deprescribing. Now, onto some tools that identify PIMS, or potentially inappropriate medications. There are at least 33 tools that provide guidance around identifying inappropriate medications. You may have heard tools like the BEERS criteria, which is an American tool that identifies inappropriate medications. And the one I've highlighted here is the STOP criteria, which was developed by a group in Ireland. There are many other ones, including the Good Palliative Care a geriatric practice algorithm, or the GPGP algorithm, and the medication appropriateness index, and even the drug burden index can be considered a PIM tool. And these tools identify which medications can be potentially inappropriate and considered as inappropriately prescribed in older people. And recently, there's even an Australian PIM tool, which was developed by Kate Wang and her team, and this is specific for the Australian population. To support PIMS tools, a Canadian team have actually developed the Think Cascades tool for identifying clinically important prescribing cascades affecting older people. And the Think Cascades tool highlights the 9 clinically important prescribing cascades, which can be consistent with PIMS. And finally, but definitely not least, there are tools for engaging patients in the deprescribing or medication management process. A recent review found that there were at least 48 resources, and these varied from fact sheets, decision aids, patient education materials, and option grids but I can guarantee you that there are at least more than 48 now, because that review was done in 2019. And over the last 5 years, there have been many more developed. The ones captured here are from the New South Wales TAG and the Canadian Deprescribing Network. And another tool led by Muna Sarwan from the University of Sydney is looking at developing resources specifically for people living with dementia and their carers. So if you find a tool specifically for consumers, it's important to note whether they refer to evidence-based resources and also use language and reading levels suitable for older adults. So regarding deprescribing tools, my suggestion is if you find a deprescribing guide that you and your patients might find useful and understand, stick to it. Deprescribing is part of good prescribing, and although they might not, some might not like the term deprescribing, it clearly identifies the step which is often overlooked in the medication management and prescribing process. I hope this brief overview of resources has provided you with the confidence to continue person-centered deprescribing in your practice. Thank you.
Thank you, Sarah and Lisa. You can still submit your questions throughout the day via the chat function on your screens. So, how can consumers and clinicians work together to minimise unintended consequences of polypharmacy? To tell us more, we have Bronte Parkin.
Hello. My objective in this presentation is to briefly describe to you the example of my wife's journey with dementia, her medications, her changing behaviour, her adverse reaction to an antipsychotic medication, how it triggered a crisis in her care, how that led to deprescribing some of the medications, and how non-pharmacological interventions were adopted to manage her changing behaviours, and how it led to the development of an effective behaviour support plan. So I come from the perspective as a carer for my late wife, Glenda, who lived with dementia for 13 years, her final 3 years in residential aged care. I've been a dementia advocate for Dementia Australia and Alzheimer's WA for 14 years. And in that role, I've been a member of a number of committees which you can see on the slide, including participating in the Health Commission's development of various standards in aged care and the use of psychotropic medications. I've also been involved as a consumer on a number of university research projects across the dementia space. She was a highly educated, high-functioning careerist, a wife and mother with high cognitive reserves. The specific diagnosis was posterior cortical atrophy, or PCA, which is the visual variant of Alzheimer's disease. So on her diagnosis, she was prescribed an antidepressant, escitalopram, and a cholinesterase inhibitor called Reminol. There was little discussion about these medications at the time, simply that Reminol would slow the progression of the disease, and escitalopram was an important mood leveller as her condition changed. We took it at face value and trusted the medical specialist. Consent was not requested, merely implied. In her main initial symptom was functional blindness, a characteristic of PCA, as the visual processing parts of the brain are impaired. However, she lived a stimulating life at home with family and friends and a supportive community and travelled for almost 10 years following her diagnosis. So in the 10th year, however, she deteriorated quite rapidly and displayed periodic psychotic behaviours, as shown there on the slide: anxiety, agitation, restlessness, delusion, paranoia, aggression, sleeplessness, what we call the behavioural and psychological symptoms of dementia, or PPSD. She was prescribed another medication, the anxiolytic lorazepam, which was used as required. These psychotic behaviours occurred throughout the day in a 24-hour cycle, about every 4 or 6 hours. So again, with the second set of medications, that is these psychotropic medications, there was minimal information given to me on the risks over the benefits. In fact, I was the one that downloaded the information myself from the internet. Either that or the pharmacist who dispensed the medications had given me a sheet. Again, consent was implied, and again, I trusted the specialist. So Glenda had 4 medications, so I'm unsure whether taking 4 medications is considered an example of polypharmacy or not, but at the time, all 4 seemed appropriate. The message here, I think, is that medications are often prescribed in isolation or ignorance of the goals of care, something that I'll return to later in this presentation. So these adverse reactions to quetiapine manifested themselves with Glenda with leg muscle twitches and an imbalance, which led to her having minor stumbles and falls, the last of which was the most serious, which resulted in fractured pubic rami bones. She was hospitalised for 5 weeks. So on the day after her admission to hospital, the hospital psychiatrist met with me in the acute ward and discussed his assessment and plan for deprescribing quetiapine, advising in his opinion that it was not needed. And of course, there were other medications for pain relief that had been prescribed at the same time. The hospital physiotherapists were unable to get Glenda to stand unaided, let alone walk. And so after several attempts, she was declared immobile and was to never walk again. The quetiapine was prescribed from the dose that she entered the hospital with, which was at 125 milligrams down to 25 milligrams daily over the period of her hospitalisation. And as the psychiatrist had indicated, it would then be ceased on her discharge from hospital. She was permanently bedridden and permanently immobile at this point. However, by then, a serious and dramatic leg movement disorder had developed, a dyskinesia, which the psychiatrist also said had been caused by the quetiapine, even at the low dose and for the short amount of time that she'd been taking it. Now, I say serious and dramatic because this involved whole leg movements. If you can imagine someone lying on the bed, lifting both legs together into the air at right angles to the bed, and then swaying those legs from one side of the bed to the other. So this was the effect of this antipsychotic on Glenda's behaviour. So to protect her from injury or falling out of bed, bed rails were installed, wrapped in towels, and we had an in-room 24/7 round-the-clock carer who kept a close watch on her. During her time in hospital, there was further cognitive decline. She became non-verbal, and there was further displays of the challenging behaviours. The in-room carer, one of the in-room carers, suggested that music listening and reminiscence therapy would be useful for Glenda as her cognitive behaviour had declined. So I took in a portable Wi-Fi speaker and made up a playlist of music and songs for her to listen to, and made up a storybook of information and photographs from Glenda's life so that the carers could talk to her about important things in her life and family. This was effective, especially the music listening, because she began to click her tongue in rhythm with it and became less agitated. By now she was non-verbal as well, and other than an occasional yes when she appeared to understand something. So with her complete dependence on carers for her ADLs and being immobile, her need to be transferred to residential aged care on discharge from hospital was accelerated. The residential aged care facility was forewarned of her condition, especially of the dyskinesia. They had never met this extreme form ever before. And mindful of not using physical restraints, they did ask me to sign a waiver for bed rails, which were wrapped in towels and secured, and the bed was lowered to the floor and was pushed against the wall, and a soft mattress was placed on the floor, all for her safety. The dyskinesia diminished over a 6-month period while she was in care. So for the first 3 months, they were very risk-averse at moving her off the bed, other than for showering by hoist, into a nursing chair. This was an agonising time for me, distressed at her life lying on her back on the bed, looking up at the ceiling, not that she could see or recognise anything, and socially isolated, as she did not move from her room. It was during this time that I insisted on music listening as the only effective therapy. The television in the room was switched to a YouTube continuous music channel, and I wrote out instructions and a playlist for the carers to follow. That was supplemented by occasional visits from a professional music therapist known to us that I engaged to visit, and several of her friends from the community choir that she'd sung with had visited her and sang with her. These were effective non-pharmacological interventions, as further deprescribing occurred over those initial 6 months. And the non-pharmacological interventions were continued for the rest of her time in care. Once she was able to move to a nursing chair, she had a number of cushions that were buffered her into the chair for safety and protection. She was able to be moved around the facility, both inside and outside. And so environmental changes were another important intervention when she showed challenging behaviours. So all of these interventions were written into Glenda's behaviour support plan, together with instructions on how to communicate with her. And in addition, we included an instruction on how to communicate with her, keeping in mind that she was functionally blind. All of the communication with her was through oral means and all instructions and inputs, rather than through visual inputs due to her blindness. So without the antipsychotic medicine and the others being progressively described, management of Glenda's behaviour was guided by the behaviour support plan for carers to read, understand and follow. We had excellent communication, understanding and support from the residential care facility. Her functional blindness, her immobility, and by then being non-verbal, meant she had little social interaction with other residents. So she was in a world of her own, and music became her life's joy, and with few exceptions, her challenging behaviour was mostly very manageable. Her behaviour stabilised, and to the extent that it was possible, the quality of her life improved. So what can I say to you about what we learned from this particular experience? So these summary points are important, and in a general way, I've covered them in this presentation. I conclude by emphasising that by minimising polypharmacy and reducing unnecessary medications, it can decrease the risk of drug interactions, adverse side effects, and hospitalisation. Testing out deprescribing strategies where appropriate and simplifying medication plans without compromising care should be the goal. I mentioned earlier about the behaviour support plan and want to reinforce through my wife's example the importance of non-pharmacological interventions as a first strategy to manage changing behaviours and as an alternative to reliance on medicines. The behaviour support plan should outline clear goals and relate to the person's symptoms, their functional abilities and overall quality of life, so that healthcare professionals can tailor interventions to ensure that deprescribing aligns with the person's preferences and or their specific needs. Of course, there may be barriers to reducing polypharmacy and other enablers also for enabling steps to deprescribe, but I shall leave that to discussion with other speakers. So in conclusion, the focus should be not just on treating symptoms, but on enhancing quality of life, functional ability of the person if possible, and personal dignity through a person-centred approach to care. And I feel we eventually achieve that goal for Glenda. Thank you.
Thanks, Bronte. For clinicians in rural and remote settings, managing medicines for patients can be challenging. Let's hear from Dr. Jenny May about her experience.
Okay, well, thank you. Professor Jenny May coming to you today from Tamworth, Northern New South Wales, and I'd like to pay my respects to the traditional custodians of the land on which I am today, the Kamilaroi people. So without further ado, let's think about what are the issues around quality use of medicines in rural settings. So I guess firstly is to understand the quantum of the people that we're talking about. And certainly, as you all know, Australia is ageing. And this is a slide showing you the number of people greater than 50 years across each of our states. Now, the reason I put this slide up, it's not a rural slide, although the people that are reported are the number of rural citizens, regional and rural citizens, is to point out that in a self-reported survey about chronic conditions, there was a great variety in the number of people or the percent of these people who reported that they had those chronic conditions. And I bring it to mention that we do have such a wide spectrum of the impact of ageing in rural and regional. So we're looking at 10% of people in Victoria who nominated that they had at least one chronic long-term condition. And we look at 25% of those people in Northern Territory. So just to give you an idea of that variety. Now, when we think about the actual number of people living rural, regional and remote, I think it's really important that we acknowledge that the biggest bulge, if you like, is in people like myself, the baby boomers. And you can see on that slide the number of us in the major cities and significantly less in our inner regional, outer regional and remote areas. And we see an absolute decline in the number of people who are age of 90 and
even those over the age of 100, as we go in a gradient more rurally. Now, many of you might wonder why that is, but very clearly, as people age, we know that there is a trend to move out of particularly remote areas into more areas that have more accessible healthcare. One of the things that we need to do is to think about a classification system that we might use to understand what services are in our rural and remote communities. So I'm going to share with you Modified Monash, and Modified Monash is a well-described classification system which is quite good at looking at where we have workforce, and this is another good use of it where we have services. So MM1 is our major capital city part of it, and you can't really see that in the slide. You can see it as sort of more like dots. And obviously the major part of this slide is made up of what we call MM6 and 7, which is our remote areas. Now, more rurally, if you like, that blue slide is what we call MM4 and 5, and that's where we think about what we might have in our heads as an idea of what a rural place, a town of between 5 and 25,000, which might have a number of services, discrete services. And then we have more close to the coast in this picture, our MM3s, which are our large regional centres, and our even larger regional centres at MM2, places like Cairns, Townsville and Ballarat. Now, the reason I've shown you this slide is because when we start to think about where aged care services are delivered, it's important that we've got that vision of where those services might be on that big map of Australia. So you can see that we've got quite a lot of aged care services in MM2, and those are of significant size. We've got a significant number in MM3, which is the grey bar, and we've got quite a lot of services in that MM4 and 5, that rural, what I'm going to call red belt rural, and then you can see very small numbers, but significant numbers in remote. I think this is an interesting slide that may help us as we think about what some of the challenges are in terms of delivering quality use of medicines programs, and we think about deprescribing. So what we can see is, as I said, quite large numbers of services delivering home care, and that means in the continuum really up to MM5. So you can see quite significant numbers in that rural band, but quite a lot less in terms of the home care in MM6 and 7. You can see in terms of multi-purpose services that they really predominate in that small rural category, and they are a wonderful example of an integrated service where we see aged care beds, we see acute care services, and we see more chronic services, often all co-located in the same location. If we think about First Nations or National Aboriginal and Torres Strait Islander aged care programs, we see a predomination in our remote communities as appropriate, where we have substantial First Nations communities. And if we think about residential aged care, again, you see this gradient, but you see quite significant numbers sitting there in our rural areas. And as I said, I've put this slide in just to give you an idea that there is a very large and significant proportion of aged care going on, but it looks slightly different depending on the contexts in which we see it being delivered. So if we want to think overall about services by rurality, and again, the reason I'm showing you this slide is to think about where our providers are, you'll see that we've got residential aged care facilities in most communities, but in our smaller communities, they may be a drive away. In our home care and support services, we're seeing them all the way through, but again, in our more remote communities, sometimes it might be local, they'll be a drive away. And again, general practice services, AMSs, community health, are all local or, a drive away, but we can see that predominance of those multi-purpose services more in MM5, and we can see a dearth of private hospitals clearly past MM4, and our public hospitals reasonably well distributed, but I'm not suggesting that there's an acute care beds in all remote locations, clearly not. What we're looking at is those challenges and integrated areas that we need to think about in the quality use of medicines. So as mentioned, in remote areas, it's quite likely that we will see people moving from those remote areas when their health needs increase to be closer to family or to care in regional or metropolitan settings. And you will be familiar with those transitions of care mentioned in the slide. And I guess what I'm trying to say is that in rural and remote, we've got all those transitions, but in a more concentrated fashion. So I think what this says to us is what models of care may need to be integrated or changed if we're going to reduce the transitions of care and if we're going to ensure that the care is as local as possible to home. And that is the focus of a number of recent reviews, and that is the intent that we continue to work to increase scope of appropriate practice to practitioners who work in rural and remote, with the end game of increasing the amount of care that can be delivered locally. I think the other challenge we have is the role of non-PBS and virtual scripts and the provision of medications through multiple modalities. I'll suggest to you that previously we had almost voluntary enrolment into our rural centres and into our rural services. And that was managed by geography because it was the only or the most local opportunity. These days, with the delivery of large amounts of virtual care, both at primary and secondary level, there is no assurance that someone's medication history is necessarily as complete as it was previously, being held locally in the locality in which they live. So thinking on, what are then the quality use of medicine challenges that are specifically about rural? And I'd say to you that one of the important ones is the gradient that we see in socioeconomic disadvantage in rural, and that is a gradient that often follows that classification that I mentioned. So with substantial numbers of the rural residents having significant challenges in terms of financial capacity, it is very clear that the cost of medicines and the cost of multiple medicines remains a big challenge for those who often live outside metropolitan areas. In terms of supply of medicines, that is, again, more complex, but what we see increasingly is a necessity for just-in-time storage and management of medications, and this is very concerning for those who are in aged care or requiring consistent supply of medications. And that's on top of generic shortages that we've been facing in Australia in the last 2 to 3 years. It would be remiss of me not to mention storage issues, which clearly are majorly important. And we've seen in Broken Hill, for instance, in the last few weeks, a considerable challenge in terms of power delivery. And I need you to think about how that impacts on pharmacies, aged care services, and even hospitals in terms of the management and storage and the management of cold chain, and things like immunisations, which have such a important, clear need for refrigeration. And then, of course, workforce, and I'll go into that in a little more detail. So just a little aside, the S100 program is really important to remote Australia. It's a tiny program as part of the S100 program, and it comprises 2 parts. There's obviously the PBS co-payment, which many of the clinicians and pharmacists will be very familiar with in the audience. But there's also a route for remote area Aboriginal health services to maintain supplies of essential medications. And again, this is and remains a really important supply of medication to First Nations populations who do live in remote areas, and is a program that's championed by all of us who see its impact in rural and remote. Okay, so really to the important bits and to getting from that background information to the real issues. So if I had to say what the deprescribing issues were in rural communities, I divide them into service and clinician factors and patient factors. We all know that there is a higher trend to staff turnover, and that's across many health facilities, but we're feeling it in rural and remote even more. And that's because our retention rates, as we go on that gradient to more remote areas, remains lower than the retention rates that you might expect in rural and in more metropolitan areas. Consequent on that is a higher utilisation of locum workforce. And when I say locum workforce, that's not all bad. So what we see is some very stable locum arrangements where we've got stable clinicians who fly in, fly out, or drive in, drive out regularly to service communities. They have a rapport with the communities, and there's some very good models out there of how to do this well. But looking with our helicopter view from above, that high utilisation and that high turnover of locum workforce is certainly a challenge. It is well documented that there is limited time in consultations because of the workload requirements, and we know that our clinicians, all sorts of clinicians who work in rural and remote, work longer hours or report longer hours of work than their metropolitan colleagues. And there are some challenges with the prescribing status of GPs versus non-GP specialists, and that does move into the scope of practice space, as I mentioned, and is being addressed or being considered currently. In terms of patient factors, generally complex patients present in rural and remote, and their contextual issues certainly make those patients more complex. It is important to build trust with a new clinician or clinicians, and that is challenging if your workforce and the workforce clinic or the clinicians do turn over. There are limited opportunities to participate in things like medication reviews. And there is a perception or acceptance or a stoicism that may come with a rural postcode about the need to use medication or the attitudes towards medication in our ageing clients. So if I can actually get even more pragmatic, I thought I'd actually give you the real things that when I thought about deprescribing, that came down to the issues that we face on a daily basis. For services and clinicians, getting a login to all the software required as you are a locum and you are arriving in a rural or remote community on the day that you are commencing service is a real problem. And the lack of connectivity between some of our aged care systems, some of our other systems, some of our general practice systems, AMS systems, and our hospital systems, we all know about, but actually getting a login to all those systems for a locum is really challenging. It is also fair to say that the resources such as ETG are not freely available in all locations. And I think that's one of those things that we could fix. And I find it odd that access to such useful resources are difficult to access in some clinical settings. Mentioned, as we have, the limited time in consultations, and that confidence, if you're not familiar as a locum with the system and you're not sure if you undertake a deprescribing discussion with the patient, who's actually going to support you. Now, on the patient side, we need to think about health literacy. There are many of our patients who have less than average health literacy, and the concepts that we're explaining in terms of ceasing medications and the language we use, such as withdrawal of medication, is really challenging to some of our patients, both rural and metropolitan. It is also important to weave this into the difficulty and the expectation that patients will trust clinicians that they may have only met for the first time, and that they will develop that rapport, and that those clinicians will have the cultural safety and the cultural awareness significant to support those patients undertaking that discussion. There are some practical things. I have concerns that if I'm ceasing a medication, that will the pharmacy cease to carry it? And if it is required to be restarted for a clinical reason, how long is it going to take to restock that medication in the pharmacy? And is it fair to expect the pharmacy to carry ongoing stock when they need to have a just-in-time approach to managing stock? And I think the other thing, and it's increasing, is obviously there's multiple sources of advice here. So to have a deprescribing conversation, you really need to be on top of the patient's medications from all sources. You need to understand what they know and understand about their medications, and you need to clearly involve the family or significant others in many of those discussions, given the age and cognitive capacity of many of our clients. So I know that presents potentially a slightly negative approach. It's not meant to be, but I do think if we pragmatically look at some of these factors, there are pragmatic solutions that we can offer. But I think also we need to understand the environment that we see in rural and remote communities and tailor our responses and our support to the problems that they tell us that they have. I'll leave it there. Thank you.
Thanks so much, Jenny. And you're going to hear more from Jenny in just a second. And I mean that quite literally, because it is time to introduce our expert panel to unpack this further. We have Dr. Lisa Kalajian-O'Donnell, lecturer in the School of Pharmacy, the Faculty of Medicine and Health at the University of Sydney. She's also Deputy Chair of the Australian Deprescribing Network. Mr. Bronte Parkin, Dementia Advocate at Dementia Australia, and Professor Jenny May AM, National Rural Health Commissioner, and with me in the studio, Dr. Phoebe Holdenson-Camara, a medical advisor at the Australian Commission on Safety and Quality in Healthcare and a general practitioner. Welcome to all of you lovely people from around Australia. So it was really interesting to hear from Sarah Hilmer before that deprescribing is an Australian word. I didn't know that. So go Aussie. And Sarah was also talking about the fact that in general, people are open to deprescribing, which is a really nice start. So Lisa, I'd love to start with you on how you do initiate conversations about deprescribing with patients.
Yeah, thank you. And that's a really good question. And I think it starts with, especially if I'm doing a medication review with a patient, it starts with asking the questions about what do they want out of their medicines? What do they want to get out of their medicines? What are their goals of care? Even recently, I did a medication review and I asked that question. I said, what do you want to get out of your medicines? And the gentleman said to me, I just want to be kept alive. So a lot of the recommendations that I provided were about tailoring his medications to achieve that goal. So I think it's about starting that conversation just generally and saying, okay, what do you want to get out of your medicines? And maybe it's about, just being able to walk down their driveway into the mailbox, so improving their function. So let's reduce some of those medicines that are stopping them from functioning. And it's about that type of conversation. I think, talking about goals of care is really important.
And Phoebe, what sort of response do you get when you're initiating these conversations with patients?
I think generally very good. I think it's just really about how we set up the conversation. So we've got to make sure that there's enough time. And then I think, because I'm a GP, I'm not necessarily doing medications reviews in the same way that Lisa's described. And so the patient may have actually come to see me for a different reason. And so it's really important then that I actually signpost and ask permission. It might be a good opportunity, I'm thinking, to have a chat about your medications and whether they're working well for you, and whether we should review them at all. Is that okay with you? Is that something you'd like to do today? And then I think if they say yes to that, then you're really getting some buy-in to the process.
And that's the sort of language you would be explicitly using with your patient, that you're kind of breaking from what you were originally talking about and starting a new little chat.
I think so, yes. I mean, I do think the GP management plan review or a 75 plus health assessment is a particularly good opportunity because that's yearly and the person's actually coming to the general practice, seeing the practice nurse with the intention to review everything, including their medications. And in that situation, it might be a little bit more natural, but otherwise it is probably something that's a little bit different on the agenda, and I think it's important to get them on board with that. But if we're doing that frequently enough, then our patients do come to expect that that's part of the care that we provide.
Right, right. Jenny, how does this look different in a rural or remote setting?
Well, I think the difference is that sometimes, and I think deprescribing is a team sport. So sometimes it's a matter of understanding who's on the team, because clearly the provision of medications is not just what the patient gets in their packet or in their Webster pack or administered. It's also the supply of those medications, and it's also the rapport and the trust that Phoebe and Lisa have described with essential health professionals. So identify who's in your team and identify, as Lisa so clearly said, the goals of care. I tend to use language like decluttering. It's always a good time at a health assessment or at an appropriate time to, look in the cupboard and see what's there. And often medications grow over time. They tend to be added to rather than subtracted to. My comment is that it is best done over time, and both Phoebe and Lisa have alluded to that. Patients don't appreciate really abrupt conversations without time to digest it themselves, and the patient is the absolute partner in the decisions about medications, both the commencing of them and, in our case, what we're discussing, the reduction.
So Bronte, as we heard before from Sarah, deprescribing is an Australian word. It's a new word and it's very much used, I think, in the medicine space, but not maybe necessarily so much in the community. Do you remember when the concept of deprescribing first kind of came on your radar?
Well, yes, it was really at the point of the crisis that I described with my wife's admission to hospital. I'd never come across the word myself then, and I'm sure I would be representative of the great majority of average Australians that we've never heard of polypharmacy or deprescribing as concepts ever before. So I was saying earlier to Lisa that the information that has been given in this symposium today, is very important for the general population to learn about, and from my perspective, for people who end up living in or being supported at home under the aged care umbrella, or even in residential aged care, that those patients or clients, call them what you like, should have access to this information and have a good understanding of it. And picking up on Jenny's point, she's taken away the very words I used. She used team sport and partners. I think it is a partnership between all the parties involved that can achieve what's being aimed in this symposium. We've mentioned the goals of care as being vitally important. So these things are not taken in isolation. And I guess, to be slightly critical, where, we tend to have a very clinical care focus on the situation for older people, and particularly those in residential care. So as an advocate for dementia, good quality dementia care, I would be advocating for, a more humanistic approach to care to get good outcomes, and that requires understanding between all the parties involved, and fantastic or excellent communication. I think that's a key, so that everyone is aware of the circumstances and the situation and the prospects and the outcomes that might be achieved.
I can feel Phoebe nodding furiously next to me here.
That's right. I mean, just going back to what Jenny was saying about it being a process, I think in my experience with my patients, it's a process that usually spans many consultations and even maybe months or years, and then that idea as well of that it's not just between yourself and the person, the patient, but that, they might want to bring a family member along to that next appointment, or they might want to bring their daughter who, might be a pharmacist, might be a nurse, or might just, understand their needs and their desires better. And so, yeah, I do think that, we talk a lot about patient-centred care and shared decision-making, but I think particularly when we're talking about older people and if they have dementia or cognitive impairment, then it is important to think as well about shared supported decision making, which is where a carer or a loved one is also there to support that person as they make those decisions alongside the clinicians.
So on one hand, you've got the patients obviously at the centre of this, but you've got them and their support network, but then there's all of the various clinicians who are involved in someone's care as well, and the medicines that you're looking at might not have been prescribed by you, they might have been prescribed by a cardiologist or a neurologist. Lisa, how do you approach that conversation when perhaps the patient's like, but my cardiologist has prescribed this for me?
Yeah, no, look, this is a very interesting question, a very difficult one to navigate because even when we do the research about the challenges and the barriers of deprescribing, we do see a lot about passing the buck. So it's, I didn't prescribe that. It was someone else, so it's their responsibility. But I think it's about, as Bronte said, opening up that conversation. Okay, we can't just dismiss it altogether. We might, not have the time in a consult, but there's other opportunities that we can perhaps have that conversation and go, look, I know that your cardiovascular, specialist prescribed that for you, but that was about 15 years ago. And if that's something that we have to continue, by all means, let's continue it. But I want to open that conversation up with that specialist now. And let's reevaluate and see, is that something appropriate for you now in your current circumstances, in your current clinical needs? And then if it's not, then let's walk you through deprescribing that. But you're not going to be in this alone. We're going to be here with you, supporting you. We're going to be monitoring you. We're going to let us know if you feel unwell or if you're not feeling well, and we will support you. We might have to reintroduce it. So give them the actual steps about what is going to happen to them, and then they'll start opening up that conversation about, okay, I feel a bit more comfortable. I know what's going to happen, and I know where to go to if something bad does happen. In general cases, as Sarah outlined in her talk, that it's quite safe to deprescribe. But if in the rare circumstances that something does go wrong, or if the symptom or the clinical condition comes back, then it's not like they're going to be completely dismissed. We're going to support them and get them through that process. And I like that idea of decluttering that Jenny has said. It is about having a look and see which one is making the most noise here, and let's get rid of that noisy one and making it just a nice, neat cupboard, and that will spark joy for us.
It does sound like such a lovely conversation that really takes a bit of time and tenderness. Jenny, how is that practical for perhaps a rural GP who has a big long patient list, maybe doesn't have the luxury of a really long relationship with those patients and maybe doesn't have a lot of supports around them?
So obviously that is challenging, Tegan, but I think there's two things. One is, as I said, think about the team, think about who's on that team. It may be that the registered nurses at the residential aged care facility or the home care worker is also an attentive and important part of this team, and they may come with a request, or one of Lisa's colleagues may have been able to do a medication review, and so the opportunity presents itself and some of the pre-work is done, so it's not like you're having to take on the whole journey. I think the second thing that I really want to emphasise is language is so important, and what I find with my rural patients, and I love it, is that they really want language that understands where they're coming from. And one of their real concerns with medication or deprescribing is that we're withdrawing care. All right, that's that underlying concern. I've reached the end of the miles, and actually you're not going to bother giving me these medications because they're expensive medications and I'm not worthwhile anymore. So you've got to be so careful about language, and you've got to try and think about, walk a mile in the patient or in Bronte's case, the partner or the carer's shoes, and just see what they're seeing. So medication deprescribing makes absolute sense if you've got an appropriate analogy with farming or with something that the person can understand. And that's why my decluttering works for me, because a lot of my older women absolutely pride themselves on the way they keep their cupboard. So decluttering is a concept that's close to them. So language really important, and you can do it. And rural GPs are busy, but many of them provide stellar care, and deprescribing is part of that stellar care. So we're building them up, not, there aren't that many shortcuts, but it can be done if you're part of a process.
Bronte, do you
Just
feel like
picking up
this?
on that point.
Yeah, please.
Yeah, I think that's a very good point, and it reminds me of, I think it was Lisa or Sarah earlier in their presentations that talked about non-pharmacological interventions, and I think in what Jenny's saying there is the conversation that's had with the person or their family is that, you can still have quality of life without these medications, if they're not critical, and to demonstrate that if you take these alternative interventions of a non-pharmacological nature, they're still able to live well, hopefully live well, and that's the kind of feedback that they should be receiving, and supports this whole notion of deprescribing. The other side of the coin, if you like, is non-pharmacological interventions, and I can talk more about that with behaviour support plans when it comes to dementia care and aged care, because that's a critical part of that as well.
Yeah, talk about that.
Well, as in my presentation, that was a critical element of my wife's care after the crisis of having that side effects of that antipsychotic that I described. And, through the aged care sector now, both in home care and in residential care, particularly for dementia care or people with other cognitive issues, it's almost mandatory, or if not required, to have a behaviour support plan, which does examine these things. And, the new standard on the use of psychotropic medications certainly outlines that strategy. There's support around for people, for aged care providers and others to develop plans, and it goes back to what some of the clinicians here have been saying. It requires a very deep, knowledgeable understanding of the person, the patient, or the client, or the resident, in order for that plan to be effective, because you're looking for alternative strategies, basically, for care, rather than relying on or administering medications. And that can be quite challenging, and it does throw up the issues, at least in the residential sector, of the pressures of time and resources as well. But that's about the only option that would be available to sort of manage people's changing behaviours, particularly in the dementia space.
Phoebe, do you want to talk about these resources that are available from the Commission?
Yeah, thanks, Bronte, for sharing your experience, and also for talking about the appropriate use of psychotropic medications in people living with dementia and in residential aged care, clinical care standard that we released at the Commission recently. And you've spoken already, Bronte, about just how important that behavioural support plan is in supporting that person if we aren't going to be prescribing psychotropics. So that's antipsychotics, benzodiazepines and antidepressants. I think at its core, it's really about knowing that person very well, and not just knowing them, but having a relationship with them. And so, we all know of people who have dementia, who are in residential aged care facilities, and perhaps antipsychotics have been used to try and help manage perhaps their anxiety or their wandering in the evening, or some challenging behaviours. But often, if we know them well, then we'll know that actually that person loves Mozart, and if that's playing during the day, then that helps to settle them. Or if somebody comes and visits them more frequently, then that helps. And it's really about having that intimate knowledge and relationship with the person to help them in those challenging times. And so it is that idea that if we are going to be trying to deprescribe a medication, particularly if we're talking around antipsychotics, opioids, antidepressants, as opposed to whole other classes of medications, then we do need to actually have something else to offer. And it is those non-medication approaches that we know are effective, but also take resources. So we've really got to invest in doing that meaningfully.
Yeah, and it strikes me that a lot of... Sorry, say that, Bronte?
Sorry, you did say butt in if we wanted to make a comment. I think that point about that Sarah was saying, it reminds me that the conversation, particularly with people with cognitive impairment, has to involve the families or the loved ones of the person, because anecdotally, and I'm aware, I'm sure clinicians are, that once you start a course of deprescribing with, in the case of dementia, the behaviour may revert or become more serious again, and often the families don't like to see that, and then engineer for the medications to be re-prescribed. I've heard that from aged care providers, and that worries them, because they're working at odds with what they are aiming to achieve in the deprescribing process. So it goes back to this partnership thing. It's not just with the resident in the case of aged care, it's also with their families and loved ones who support them, because they have to have a deep understanding of what this all means, and what there are more effective strategies to do this, to work on this.
And it strikes me that what's really needed here, if you're going to have meaningful conversations with people, is health literacy, and the patient or their carer, whoever the layperson is who's part of this conversation, is feeling included and they're up to speed with what's actually being communicated. Lisa, what can we do to ensure that health literacy is there and help build it if it's not?
Yeah, no, that's a very good question. And I think there's a couple of things I want to talk about in this aspect. There's a lot of consumer resources that are being developed, and if you find them, download them and use them. They're written in very basic health literacy language, so it's clear and the communication is clear. There's also versions in different languages as well. So there's, if you're dealing with multicultural and cold people, so culturally, linguistically diverse people, these resources will be useful for these people because it's speaking to them in their own language and they can understand that a bit better. However, it is a challenge, and it's maybe it's about using some of the techniques and skills that we use as clinicians for communication. Maybe it's drawing a diagram, maybe it's writing it out in 3 steps, maybe it's about simplifying it in a way that is understandable for them. And if you tell them, do you get what I'm saying, and ask them, do you get what I mean? I think that even is a good conversation starter, and saying, look, I actually don't know what you mean. And then you can tailor the information again back to them. So I think there's a few things that as clinicians we can do to improve the communication of deprescribing for our patients.
Phoebe?
Yeah, I would agree with all of that, Lisa, and I think wrapping up that conversation is just so important. So say you've had that 10, 15 minute, 20 minute conversation where you sort of go through that list, you work out what's this person's priorities, what are their goals of care, and you make a decision, okay, we're going to try and reduce this particular medication to this dose, or we're going to try have a weaning plan, this is how we're going to do it. And then I think that wrap up piece is so important. As Lisa was saying, to make sure that you really have brought the person along on the journey and that they have understood it, because there's actually a lot that's being discussed in that conversation, and as you said, actually requires quite a bit of health literacy. So yeah, we can say, do you have any questions, or have you understood that? Or we can actually explicitly use what we call the teach back method, which is to say, just so I understand that I've explained things clearly enough, would you be able to just explain that plan back to me in your own words? And as they're talking to you, what I will often do is take notes, write something down, and then hand that over. And so there's really then a shared process, and that's an opportunity to go, oh, I thought I'd done a good job, but actually there's a few steps that we're missing there, because there's a lot of information being sort of transmitted in that process. And so you can clarify some of those points.
Yeah. I mean, sometimes people sort of want to nod because they want to be smart or convey that they just want to get out of the door. Like, Jenny, are there any tools that you've been able to find really work for you?
Well, Tegan, many of my patients do just want to get out of the door, and that's exactly right. And these conversations are often confronting because, as I said, even discussing goals of care is difficult, and it's often a hard conversation. My comment is just that I use the bottom of the script, the tear off bit at the bottom of the computer script, and all my patients leave with their plan written on the bottom of those bits of scripts. So I'm going to be haunted by little bits of white paper that are no doubt fluttering all over the rural area in which I work.
Not so good for sustainability, but very good for patient communication. Bronte, are there any resources that you've found that have, you go.
Yeah, just to pick up on Sarah's point, I think having that conversation, I think at least in the residential aged care sector, the role of the on-site pharmacist program that we heard some earlier speakers mention, that's probably quite a valuable element of that to provide a conduit for conversations between all the parties. It's not to say that the clinicians, the medical practitioners themselves can't communicate, but I think having an on-site pharmacist is going to be, I'm not sure it's written into their role statement yet, but that seems to me that a key link, if you like, that has got contact with all of the various parties. It's got contact with the prescribers, and it's got contact with the families and the resident themselves. So that we hold great hopes, I suppose, for that role as it unfolds. I mean, it will be evaluated, as I understand it. The gap will be, of course, what happens with people as they age who remain in their homes with support through the aged care sector. I'm not too sure about how that will unfold. So your question was, what did I find beneficial or helpful? Is that what you were going to ask?
Briefly, yes.
Well, I think I've covered some of those things. I think, in my case, it was a very specific example. Obviously, there were sort of two aspects to that. It was what happened when my wife was hospitalised and then later when she went to care. So I suppose the hospital communication was pretty perfunctory, but it was essential and necessary, and I understood that clearly enough. But I guess the good thing was that once she was transitioned to residential care, that kind of conversation continued, and with the excellent support of the residential facility and the GP who was consulting to that facility, that assisted in the continuation of the de-prescribing process. But I have to say that it's probably through my own resourcefulness that led to the suggestions about the non-pharmacological interventions, and as I explained earlier, for my wife, it was a very narrow selection that was appropriate for her condition. But I suppose generalising from that, families need to be involved, and having this, as Sarah said, having this deep understanding of a person, goes to the heart of what we mean by person-centred care. I mean, all of the aged care standards, clinical care standards, we're throwing in the word person-centred care everywhere. But does everyone have the same understanding of what that really means? And I think for me, it means, looking at the person as an individual and having a very deep and knowledgeable understanding of them, so that you can choose and trial various interventions that are not necessarily medication-based.
Lisa, there's a lot of people who are joining us today who aren't prescribers. What's the role of non-prescribing healthcare workers in helping support patients here?
I think, as we've already mentioned, I think communication. So I think a communication about, like, let's say if we've got lots of nurses watching, they're the ones that are seeing the patient every day, giving them medications, especially in residential aged care. They might be seeing them weekly or even twice weekly in their home. They'll be able to see that there's changes happening, or there's side effects happening, or something that's happening with their medicines. Maybe they're not taking it right, maybe they're taking it too much. There's all these things that they can see, and I think communicating those with the healthcare practitioners that are involved, I think that's key. Another thing that perhaps nurses can do is also have that conversation about their goals of care, and initiate and communicate that to all the team that's looking after the patient, and talking to the carers as well. Yeah, I think those are the conversations that they can have.
We're almost out of time for this session, but I'd love to get from each of you a little nugget that you hope people take away from this as one thing that they might be able to do differently or keep doing if they're already doing it. Jenny, from you?
I'll go back to my language. So consider decluttering.
Bronte, one small tip from you?
I'd say know the person really well.
Lisa?
I think download at least one consumer resource, print out a few in your clinic and have them lying around as conversation starters.
And Phoebe?
I would say never consider prescribing as a set and forget type process. It's always worthwhile reevaluating, reassessing, and doing that in partnership with the patient.
Oh, well, thank you so much to all four of you for sharing your time and your insights with us today. We really appreciate it.